Good morning. My name is Luis Diaz, and today I'm going to be presenting an individual where a pulmonary group was consulted. The patient was receiving dialysis this morning when she started feeling short of breath. The dialysis center staff telephoned EMS. This 61-year-old Hispanic female was transferred from her dialysis center at 11 o'clock this morning to the emergency room via EMS due to hypoxia. The patient was receiving approximately 2 of her routinely scheduled 3.5 hours of dialysis when she became hypoxic, short of breath, and was noted in respiratory distress. The oxyhemoglobin saturations were noted between 60 and 70%. The dialysis staff quickly titrated the oxygen from 1.5 liters to 3 liters nasal cannula, but her oxyhemoglobin saturations continued to drop. She was transferred to this hospital after failed attempts at maintaining her oxyhemoglobin saturations above 90%. She was placed on a 100% non-rebreather mask by EMS. The patient says that she had a fever of 102.0 Fahrenheit degrees and flu-like symptoms since Friday of the previous week. She states that the fever subsided at home after treatments with over-the-counter Tylenol, but she continued to have chills and body aches. She also complains of a cough that is productive with clear to white phlegm that also began Friday of the previous week. She does complain of some shortness of breath now. She denies any chest pain. She states she wears 1.5 liters oxygen via nasal cannula at home as her baseline. She states her oxygen concentration was decreased from 3 liters nasal cannula to 1.5 liters nasal cannula on Monday when she saw her primary care physician at his office. Her current chest x-ray and chest CT revealed multifocal pneumonia. Her chest CT also revealed pretracheal enlarged lymph nodes, cardiomegaly with no pulmonary edema, small hiatal hernia, and extensive coronary artery calcifications. The patient arrived directly to the emergency department with her AV fistula still accessed. A D-dimer was obtained for evaluation of possible thrombus, which proved unremarkable. The on-duty dialysis nurse was called to de-access the site. No bleeding or hematoma were noted, and a good bruit, thrill, and distal capillary riffle were present. A review of past medical history reveals diagnosis of chronic obstructive pulmonary disease, hypertension, end-stage renal disease on dialysis, Monday, Wednesdays, and Fridays, morbid obesity, blind bilaterally, peripheral artery disease, and diabetic retinopathy. The patient's current medications include Duoneb 0.5 milligrams to 2.5 milligrams inhalation solution Q6, heparin 5,000 units, subcutaneous injection Q8, Levaquin 750 milligrams IV piggyback Q24 hours to be administered over 90 minutes, Maxipam 2 milligrams IV piggyback Q8 hours to be administered over 30 minutes, Mucinex 600 milligram tabs oral Q12 hours, Pepcid 25 milligram tabs oral daily, Tylenol 650 milligram tabs oral tab Q6 PRN for fever greater than 38.5 degrees Celsius. The patient's home medications include amlodipine 10 milligrams oral daily, calcium acetate 667 milligrams oral capsule TID, carvedilol 12.5 milligrams oral tablet BID, Duoneb 0.5 milligrams to 2.5 milligrams inhalation solution Q6, Florinix oral tablet chewable TID, Mucinex 10% 200 milligram via nebulized inhalation BID, multivitamin adult oral daily, Protonix 40 milligrams oral delayed release daily, and Renavite oral tablet daily. The patient has no known drug allergies, no known food allergies, and no other sensitivities. Family history includes a father that is deceased due to emphysema at age 78. Mother is deceased due to breast cancer at age 58. 3 children are alive and well. The social history includes the patient is a retired school teacher and admits to social alcohol consumption. The patient is a former smoker and smoked half a pack of cigarettes per day from age 14 until approximately 10 years ago. She denies injuries, abuse, neglect, or any of that sort in the household. Review of symptoms. The patient complains of fevers and chills. She denies sweats and weight loss. She complains of being blind bilaterally, denies ear pain, nasal congestion, or sore throat. She complains of mild shortness of breath and productive cough with clear white phlegm. She denies chest pain, palpitations, syncope, swelling in the legs, dyspnea, or exertion. She denies nausea, vomiting, diarrhea, abdominal pain, or difficulty swallowing. She denies any rash, pruritus, or abrasions. She complains of diabetic ulcer to the right great toe and left second and third and fifth toes. Physical exam reveals a temperature of 37.2 degrees Celsius, apical pulse of 91, respirations of 25, blood pressure 113/62, SpO2 on 1.5 liters of nasal cannula, oxygen at 93%, and a dosing weight of 96 kilograms. The patient is well nourished, developed individual in no acute distress, inoculation to the right eye, normal conjunctiva, sclera not icteric, normal cephalic, normal hearing, moist oral mucosa, no sinus tenderness, tongue within normal limits. The neck is supple, non-tender, no lymphadenopathy, and no thyromegaly. Regarding the lungs, they are diminished throughout the lung fields, no respiratory distress, no wheezing, rales, or rhonchi, no intracostal retraction. Cardiovascular proved to be unremarkable, normal rate, regular rhythm, no murmur, gallop, or edema, no carotid bruits, no jugular vein distension. The abdomen was soft, tender, non-distended, normal bowel sounds, no masses, no hepatosplenomegaly. The skin proved to be warm, dry, no rashes, normal turgor, no induration. Diabetic ulcer to the right great toe, left second, third, and fifth toes were noted. Current lab results include a glucose of 149, a pH 7.4, CO2 of 39.8, O2 of 68.7, bicarb of 24.1, base excess of negative 0.6, WBCs of 18.4, RBCs of 3.55, hemoglobin of 12, hematocrits of 37.5, platelets of 167, sodium of 135, potassium of 4.7, chloride level of 99, CO2 of 26, BUN 56, creatinine 9.1. BUN and creatinine ratio was noted as 6, calcium level 7.8. Anion gap was noted at 10, ALK-Phos 431, total bilirubin 1.2, AST 49, ALT 46, protein total 7.6, albumin level 2.5, lactic acid plasma 1.7, troponin 0.551, influenza A and influenza B were both negative. Microbiology studies are pending at this time. The diagnostics include a CT without contrast of the chest. Impressions were noted as findings are most likely secondary to multifocal pneumonia. Advice follow to clearing for exclusion or other etiologies. Enlarged pretracheal lymph node with numerous smaller mediastinal lymph nodes. These may be reactive. Cardiomegaly, no pulmonary edema. Some atherosclerosis with extensive coronary artery calcifications and a small hiatal hernia was noted. The assessment and plan for this patient includes acute on chronic respiratory failure with hypoxia. O2 keep oxyhemoglobin saturations above 88% at all times. Titrate O2 as necessary to meet that criteria. Multifocal pneumonia, broad spectrum antibiotics with Levaquin and cefepime already began in the emergency room. COPD with exacerbation, continues Symbicort or equivalent, Mucinex BID, end-stage renal disease on dialysis, consult nephrology due to abnormal BUN and creatinine at this time. As mentioned before, the dialysis nurse did remove access to the fistula. No adverse effects were noted at this time. Uncontrolled type 2 diabetes mellitus, blood sugars AC, HNS, with sliding scale, A1C to be completed tomorrow morning. Peripheral artery disease, we're going to start the patient on aspirin 81 milligrams daily. Moderate hypertension, continue Coreg and amlodipine as ordered previously by PCP. Diabetic foot ulcer, consult wound care for wound care management and consult wound care MD. Diabetic retinopathy, patient is legally blind. Address safety concerns while in the hospital. Morbid obesity, consult dietary for weight loss recommendations. In summary, the combination of presenting signs and symptoms obtained from the nursing staff as well as the patient, laboratory findings, and diagnostic findings are suggestive of multifocal pneumonia. The acute of chronic respiratory distress is secondary to the presenting pneumonia. That is all. Thank you.